Yes, others give that control to me.
Sir, we are live now, live, sir. Now you can start it.
Okay. Welcome, students. Today we'll be discussing on meningitis. So the meningitis is one of the important disease in the CNS. So a good number of questions have been asked in NEET. So it is important from your NEET point of view. Even in clinical medicine, you will have to see some cases with meningitis. When you discover meningitis, what is meningitis in fact? So the meningitis is actually identified as infection here. It is meningitis is actually inflammation. It is actually it is not infection alone. I mean not alone. I mean it is inflammation. It is inflammation that you know very well from this itis. Whenever you come across itis, it is inflammation. This inflammation can occur. Hold on. Yeah, it can occur because of infection, trauma, chemical, and many more things. Now, these are the possible causes for inflammation. Of all the things, in medical point of view, we are more concerned with infection actually. Infection of the meninges. Even chemicals like drugs, maybe ibuprofen, and you can see that the intrathecal we give anesthetics for doing LP while doing spinal anesthesia. When they are doing spinal anesthesia, they give intrathecal drugs. They also can cause meningitis. So the trauma could be non-surgical also, maybe RTA, road traffic accident, which can damage this one. Also following neurosurgeries. Neurosurgery they also can cause meningitis. So the causes of meningitis is not alone infection. From medical point of view, the traumas, chemicals, these are all can cause meningitis. Now, before getting into meningitis, let us try to understand what are the meninges. Can anybody tell me what are the meninges? How many layers of meninges are there? 1, 2, 3. How many are there?
Three.
Three. Yeah. There are 3 meningitis. Of them, 2 are innermost. This is arachnoid matter and pia matter. And the outer one is, what is this? Dura matter. So here you can see a diagram. The outer one, dura matter, is hard and thick. This is the bone, skull bone. Whereas this is, what is this? Dura mater is very hard. Up below that there is a arachnoid matter. And this is pia matter. Yes? Any doubts? Okay, below there is a pia matter here. This pia matter will go down into the cerebral gyre.
No, sir.
Yes? What is it? Okay. Pia matter will go down into the cerebral gyre and come out like this. It is tightly adherent to the brain, this pia matter. And arachnoid matter is, and in between this arachnoid and pia matter, there is a space. This space is called as what? Can anybody tell me what is this space called as?
Subarachnoid.
This subarachnoid space. And meningitis is limited to, I mean, when we say meningitis without specifying what we mean inflammation of these two, this much. We exclude this actually dura matter. That is, when we say without qualifying, when we say meningitis, we are actually talking about leptomeningitis. That is the inflammation of arachnoid and pia matter, and subarachnoid space could be even ventricles, ventricle and all that, it will be there. So we are talking actually about leptomeningitis. So what is this inflammation of dura mater is called as then? If there is inflammation of dura mater, what it is called? Can anybody tell me? What is called as patty meningitis?
Macky meningitis.
Yeah, it is called as patty meningitis. This is leptomeningitis. This is more common with the traumas, but we are from medical point of view, we are actually dealing with this. Leptomeningitis. We am actually today I'll be discussing on leptomeningitis, not much about patchy meningitis. Fine. So this is a, and you should also know that this subarachnoid space is the lot of blood vessels will come from here, go down here like this. There's a lot of space here. CSF fluid is usually, how is it? It is clear. It is clear. It hardly contains neutrophils less than 5 per cubic mm. Such a low is the neutrophils. The protein is also less, and sugar is usually 2/3 of the blood sugar. This is a usual picture of CSF. CSF is not rich with complement, antibody, nothing is there. It is a clear fluid, just like a distilled water, you can say, but not exactly. It is a very clear fluid. That's how is the CSF. So when it is such a clear fluid, it has little defensive mechanism. What is it? All neutrophils are not there, antibodies are not there, protein is there, nothing is there. So it is, what is it? It is a sterile fluid like. So it can't protect itself, left alone. So CSF is a defenseless. It is a defenseless fluid. You should always know that. Whenever something gets into CSF, and if it can infect, it can really cause havoc because of that. Now, as far as when it comes to meningitis, we'll be discussing about, I said, infection as being the predominant cause. So the meningitis clinical picture usually is the patient will have decreased level of consciousness, not necessarily. Now, when I talk about decreased, then I want to discuss differentiate between encephalitis. Can anybody tell me what is encephalitis?
Inflammation of brain
Brain
Yeah,
parenchyma.
very good. It is a inflammation of a predominant brain parenchyma. So here the meningeal things are less. So inflammation of a brain parenchyma. If there is encephalitis, the loss of consciousness will occur in the early stage of the illness before the raise ICT. Even in meningitis, the intracranial pressure when it goes down, the coma can come up. But in encephalitis, the patient will present with the consciousness problem here. You got it? In encephalitis, patient presentation is the problems of consciousness here. Whereas in meningitis, unless the patient goes for raise ICT or or if there is an encephalitis, the patient level of consciousness is preserved. That is one thing you should remember. And the definitely in encephalitis, scissors being the more commoner than meningitis. Of course, in meningitis there can be scissors, both focal and generalized. Focal, it could be because of the vessels getting ischemic or infarct. I'll come to that. How the vessels, the blood vessels which supply the brain can become, we can see, oh, we're not able to see my face. Okay. Fine. When the blood vessels supplying the brain, they can cause ischemia. So then infarct, that also can cause focal. Okay. Then there can be some complications like hyponatremia in meningitis that can cause generalized seizures. This is about seizures here. I'll just discuss them in more detail when I go to the next slides. So as I told you, there is a intracranial pressure. This can happen because of vasogenic edema, interstitial edema, and last is cytotoxic edema. So what is the first one? Vasogenic. Second one is interstitial. Third one is cytotoxic. These are three types of edema can occur. Along with that, there can be hydrocephalus. What is hydrocephalus? Anybody can tell me what is hydrocephalus? Dilatation of the
Ventricle.
ventricle.
Well,
It could be obstructive or non-obstructive, or communicating or non-communicating.
non-obstructive.
Okay,
Communicative.
there are two types of Hydrocephalus.
Yes.
That can be both. Both can occur here. Both can occur here. Okay. A stroke, as I told you, there is a ischemia infarct. Stroke can be the manifestation of meningitis. These are something diversely I gave you. The meningitis not necessarily only limits itself to the meninges. In later stages, it can cause all the havoc. All the havoc. That's what I wanted to point out here. Fine. Now I just now showed you about this slide. Think so. I'll go to the next slide. Now, and this one also I discussed in the types of meningitis can occur because of infection, trauma, and chemical. Now, what are the uh, okay newborn? So the bacteria will today I'll be actually discussing on pyogenic meningitis, bacterial or bacterial meningitis. In that, according to the age of the patient, the pathogens or the organisms responsible for meningitis are different. Knowing this is very important from treatment point of view. If you know, if you suspect an organism, your antimicrobial therapy will be directed to that. So naturally, we need to know depending upon the age group, depending upon the clinical status, like whether the patient is having a immunocompetent state or whether the patient is having a what do you say immunocompromised or whether it is a old age, debilitating status. We have to look into those pictures and we'll be able to decide the organisms. Or because meningitis many times requires emergency treatment. Emergency treatment. Blood culture report, sensitivity report may take longer time, and if you keep really waiting for that, you may end up with a you may lose a patient. That's why the empirical treatment is important. When you think of empirical treatment, you should know the possible organisms in a given patient. So from that point of view, you need to know the causes of meningitis. Now, let us discuss about this newborn. Who is a newborn? Less than how much? 1 month baby.
1 month, sir.
Up to 1 month. That is, we will put call him after 1 month. We want to call him as infant. Okay. All the infant does include newborn. I want to differentiate here because the organisms are different here. Fine. So then in the newborn, so what is the commonest organism? Group B, Streptococcus. Group B,
Yes, sir.
Streptococcus. Other also called as Streptococcus agalete. It is also called as that. And why you will get this newborn infection with this type of organisms? Because the vagina, these organisms can harbor. Can harbor. So during the birth, the patient or the baby will swallow these streptococcus and can end up with the encephalitis or meningitis. That's the one thing. That end up with the meningitis. So that's one of the reasons. And this E. coli, they are common in gut. So gut. So at the perineum, they are more common. So the newborn is prone to develop meningitis secondary to group B streptococcus, E. coli, and also Listeria monocytogenesis. So Listeria monocytogenesis, we need IgM antibody. What we need? We need IgM antibodies to kill them. But mother to child only gives IgG. She doesn't give IgM because in a newborn only has passive immunity. Newborn babies have got a passive immunity. They don't have active immunity for anything for that matter. All the antibodies are derived from the mother only. So the Listeria monocytogenes, to kill them we need IgM. Because the newborn only has got IgG. So Listeria monocytogenesis, if the mother has eaten a lot of cheese and all this raw meat and all that, she may harbor Listeria monocytogenesis in her gut. So that can that can cause infection to the baby. Okay, and the patients may develop infection of this Listeria monocytosis because of that. So that is one reason of causing how this the mechanism of meningitis in newborn. Hmm? Now, after the 1 month, the other one common is in our country could be H influenza, can also cause meningitis. Hmm? H influenza could be. This requires because H influenza, if the mother is vaccinated with the HIB, anti-influenza vaccine, then mother will give IgA antibody to the baby through breast milk because all these IgA antibodies are secreted in the fluids. So IgA antibodies are secreted in the fluids. So if the mother gives through the breast milk these IgA antibodies, so the baby will be protected with influenza also. And of course, the baby can also be given HIB vaccine to protect itself. So one more advantage of breast milk is this IgA antibodies. That is one more. So that's why in India we do encourage breast milk. Apart from calories and all that, this antibody is given to the baby through the breast milk. And when you come to children and young adults, this is the common. In fact, I don't know why I forgot this Neisseria meningococci. I don't know why I did not write here. Here in young adults, it is Neisseria uh, meningococci or meningitis. Neisseria this is one more important cause. Of course, here also it can come Neisseria. Not only here also. These two groups we have got Streptococcus, Nigeria, Nigeria here and here. These two are very important. In fact, I have missed typing here. Just you need to remember this. Okay. In young adults, Streptococcus pneumonia is the commonest cause. Or overall, if you take all the population, Streptococcus pneumonia is the commonest cause of meningitis. If the question is commonest cause of meningitis, definitely you will have to give Streptococcus pneumonia. And apart from that, there is a Neisseria meningitis also can cause. In old age, Streptococcus pneumonia, and of course Neisseria, and of course Listeria monocytogenes. This is more common in both extremes of age. Always remember this. Listeria is common in the extremes of age. Listeria is common in extremes of age. So this is a little bit about the bacterial causes of Neisseria meningitis. Okay, if you got an immunocompromised patient, and if you are dealing with a patient with trauma, or neurosurgery, then what do you think? Staph, Staph aureus is one of the common causes of in a patient who has come with the Listeria meningitis. Sorry, in a patient post-surgical or a trauma, what is the common cause? What are the organisms you suspect? It is staph. You should think of staph there. So these are the bacterial pathogens which causes meningitis. I'll go to the next slide. You got any doubt here? Shall I go to the next one? You need to know
Yes,
them
sir.
because these
Yes, sir.
questions can definitely come around this. Fine. Next. Uh, Here, so what? Let us understand the pathophysiology, how the exactly the meningitis happens. So the what is the commonest root for meningitis? Is it trauma or it is a what is the common? It is hematogenous. Hematogenous root is the way that the organisms reach the brain is the commonest root. You should always remember. If the question is asked, what is the commonest root of meningitis? It is hematogenous. You should know that. Now, let us discuss. Let's start with our Streptococcus pneumonia and Nigeria. These are the classical things now, these two. Streptococcus and Nigeria. They, and if you think in a young adult who comes with meningitis, the usual place they colonize is the nasopharynx. So just like COVID, this is the place. Also, these also get here. Corona, like all those things which colonize in nasopharynx are very dangerous because they got a epidemic capacity. Hmm? Epidemic capacity. They can cause an epidemic. And I think so in 1996, there was a epidemic in Sub-Sahara due to this organism. Epidemic. Because they were, it was caused because of this only. When they colonize here in the nasopharynx, when if the people are, I mean, a lot of people are living in a close contact, then you can imagine the amount way it can transmit. So similar to our COVID, it can cause havoc. So the patient who has come with these causes of meningitis, what you should do is you should screen you should screen the relatives or the close contacts, or you may give them chemoprophylaxis immediately. It's a prophylaxis or something. You should give them so that they do not complicate to meningitis. You should give them immediately because chemoprophylaxis is given to the patient relatives or close contacts. Maybe all is a son, mother, whoever. You should give them immediately so that they don't develop the meningitis because of these organisms. So that is one thing you should always remember. Now these organisms, they uh, what they do is, this is a nose. Yeah, okay. Here is a nasopharynx. They colonize in the nasopharynx here. Hmm? They colonize in this is the nasopharynx. Imagine. See, in the nasopharynx, there are cells. We have got epithelial cells. These organisms colonize here. They may stick to this with the fimbriae, especially which one? Streptococcus. They can stick to this with the fimbriae. When they stick to this fimbriae, or these may secrete IgA antibodies. So, sorry, these are they have got capacity to destroy the IgA antibodies. These organisms have got a capacity to destroy the IgA antibodies, or they too have a fimbriae. When they got fimbriae in the nasopharynx, they'll get attached here. That is very important because you can imagine in the nasopharynx you got a cilia, and also the airflow is down here. So airflow, or whenever when these things are there, these cilia will propel them out, or they may either go into the stomach where the acid will kill them. Fine. If they got a fimbriae, they can attach here. So this will allow them to get stuck to here, and they get the opportunity to go through this because they get a sufficient time to go through this. How they go through the this epithelium, or they could go by endocytosis here. Whatever epithelial cells, now what they do is they will go through endocytosis. Through the cells only they'll go. They form a vacuole. Inside there is a organisms. Then they'll come out and to the blood vessel here, or interstitial space here. They'll go. Or they may lies the tight junctions here and go. These are two ways these organisms will enter the interstitial space or into the blood vessel. Okay. Once these organisms reach the blood vessel, inside the blood vessel, these streptococcus have got a, what they got surrounded. What is that? Oh, what is this? What I'm drawing? Lipopolysaccharide. Yeah. This lipopolysaccharide is the one coating around this bacteria. This because of this lipopolysaccharide, our complement cannot kill them. So this forms a one of the major protection for this bacteria. So thus they survive in the blood. Okay. Okay. Thus they survive in the blood. When these enter, what I'll do now, I'll go to the brain here. In the brain, you got ventricles. These are ventricles of the brain. In the ventricles, you got what here? What you have got here? Choroid plexus. Choroid, choroid plexus. So these are richly connected with the blood vessels. Blood vessels will come and drain here. Inside the blood vessel here, these organisms through the choroid plexus they enter the ventricles more often. They can even through the capillaries they can go into the subarachnoid space just straight away. More often they come here. Huh? There is a surrounding subarachnoid space. Here also they can come, but more often through the choroid plexus they enter the what? CSF. So once they are in the CSF, they are the bosses because there is no defense here. There is no defense. Chinese occupied Tibet, na, like that, no defense. Similar to that, once they get here, there is nothing like. So it is CSF is a first class place for them to multiply. Now, when they multiply, really nothing happens. When they multiply, nothing happens. Once they multiply, they some of them will die. They have to die, na? All those living organisms have to die. When they die by themselves also, they release toxic substances. Toxic substances. Now the problem starts. Our now the problem starts. When they release toxic substances, these will induce pro-inflammation. Actually, initially, the death of the bacteria by themselves will initiate the pro-inflammation. It will cause, it will make the all the cells here. It could be microglia, all the cells here inside here. It will induce them to secrete interleukin 6 or all chemokines, all the that even free radicals, all of them will be secreted here into the they'll get secreted. Once these come into play, then the real fight starts. The first real fight starts. This is the one, our host defense, which is the reason for the damage to us, actually. So, this inflammation is amplified by all these chemokines. These chemokines, apart from that, they will cause vasodilatation. Vasodilatation. Further, the more blood will come inside. Further, the more blood will come inside and cause more problem. Okay, more blood, more neutrophils. The neutrophil also will come. Proteins, protein also will come. Protein will get secreted because the permeability of this blood-brain barrier permeability is increased. The proteins also will leak inside. Then antibodies, because proteins are secreted because just to give the antibodies inside. Proteins are also come inside. Leukocytes will also come into play. But this being a free fluid, like our leukocytes cannot kill them. Our leukocytes are trained to kill in a solid place. Like it should have some thickness there, should be there. They're trained for that. But the CSF being very fluid in nature, it is very difficult to kill them. So our defense which has come will only damage us. It won't protect us. The defense, the host defense, will only damage the host itself without actually killing the bacterium. So they continue to produce the toxic substances, and our body will also throw toxic substances will only worsen the problem, leading to meningitis. Now, as these things go on, it will form exudates now. It will form exudates. Exudates. These exudates, this is a brain, suppose. Brain, this is a skull up. Now this is the base of the brain. Base of the brain. Now the blood vessels will be entering here. From the base of the most of the blood vessels enter the brain to the base of the brain. You see foramina magnum or all those internal carotid artery and all that, they enter the base of the brain. Because of the exudates, they come and fall in the due to the gravity here in the base of the brain. Okay, when they come here, these exudates, this will actually will cause what? They'll crush these blood vessels. So, although there was initially there was a dilatation of the blood vessels, this leads to constriction of blood vessels, leading to ischemia. Ischemia. So initially there is a dilatation of the blood vessel, later there is a ischemia of the blood vessels. This ischemia will cause infarct, stroke, and all those stuff will start. Apart from that, these leukocytes or these leukocytes always also involve the micro vessels here, micro vessels, and there is a thickening. Thus also there is a ischemia production. Not only base of the brain, when the neutrophils go into the wall of the capillaries, they will also cause decreased lumen, so thus leading to ischemia. This also happens. Apart from that, this is a brain. Hmm? This is a here. This is a sagittal sinus I'm showing here now. This is a sagittal sinus. Hmm? This is a what is this? Sagittal sinus. This is subarachnoid space. Subarachnoid space. Sorry, hold on. Here, this is a subarachnoid space here. This subarachnoid space, which has got a connection to sagittal sinus. So cerebral, the CSF will drain into the sagittal sinus like this. Now these exudates, because the CSF has become more thicker, this will get plugged off. This will get plugged off. Now when this get plugged off, the pressure here goes up. This is because raised ICT. This is one more reason. This is a one more reason of ICT. You can imagine. So I'll come to ICT now. How the ICT happens? ICT happens because of vasodilatation initially. You can imagine vasodilatation, vasodilatation and increased permeability. These two will lead to what type of ICT? What type of edema? Vasogenic edema will cause. Now we'll come to interstitial edema. Interstitial edema. This happens because of the mechanism just now I told you. This one, subarachnoid space here. The subarachnoid space is connected with the sagittal sinus. When this get plugged up, there's a back pressure that will cause interstitial edema. Now the third one is what I told, cytotoxic edema. Cytotoxic edema is due to the cell death. Cell death. Cell will die because of the exudates, and also it also because of hypoxia. Hypoxia, why it happens? Because of ischemia. I told you the mechanism of ischemia. When ischemia occurs, there is hypoxia. Hypoxia causes cell death and cytotoxic edema. This is how the whole pathology happens in meningitis. Okay, what all I kept here? I quit. And as I made this bold here, post-inflammatory reaction is a major reason for the clinical manifestations of what? Meningitis. Okay. So same thing what I explained here, the same thing has been given in this diagram. So I think if you want me to explain it once more here, students?
No,
Okay.
sir.
Then I'll go to the next one. Okay. The clinical features of meningitis. What are the clinical features of meningitis? You got a fever, headache, nuchal rigidity, decreased level of consciousness, and nausea. Fever, you all know there is an infection means fever. Headache, it is because of ICT. And nuchal rigidity because of inflammation of meninges. Inflammation of the meningitis will cause what? Spasm of the neck muscles, and it will cause neck rigidity. Nuchal decreased level of consciousness, as I told you, it could be because of
Yes.
ICT or hyponatremia. All these things can cause decreased level of consciousness. Nausea, vomiting, and photophobia. These are all the signs of what?
Raised
Yeah,
IC.
good. Increased intracranial tension. These are all good. These are a few of the clinical features of meningitis. Okay. So these are two physical science. Many times they will ask, what is this one? What is this? The first diagram, what it shows? Who can tell me?
Sir, cornic sign.
What is Kernig sign? You need to explain it now. Can you explain that? Anybody? Students? Students?
Sir, when we
No.
move the
No. When
mm,
you
legs are from
hmm.
90 degree to 180, sir, patient feel pain in muscle, leg muscle,
So
sir.
first the patient should be kept in a supine position. Let us go a bit systematically. Should be kept in a supine position. You flux the what is the hip joint to 90 degrees. Then try to extend the knee. Okay. Then try to extend the knee. When you try to extend the knee, there is a pain here. There is a please adjust the webcam. Okay. Okay. Uh, then try to extend the knee. Okay. So here there is a knee pain, hamstring muscles will go into spasm and that will cause pain. So that is a sign, that is what we call Kernig sign. Now, what is this Brodowski sign? Shivani, you tell me. Manjunatha, Manjunath,
Sir, on flexing the neck.
Flexion.
On flexion of knee joint and slightly elevation of the head, and when we try to touch it to the chest, sir, there will be pain and rigidity will be.
where?
Neck, sir, neck rigidity, and here extension of the knees will be there.
What you are telling? Which sign you are telling? You are talking about Brodowski sign, na? Anybody else? Shivani,
Sir, if we try to flex the neck, there is automatic leg movement.
flexion you tell them. You should not use such generic term. There is a flexion here. If you flex this neck, there is a flexion of hip. That's what it is.
Flexion of hip, sir.
Yeah. So if you flex the neck, and there is a flexion of hip. This is Brodowski sign. Fine. That's all is Brodowski sign. You got it? Shall I go to the next slide? Either
Yes, sir.
they'll put,
Yes.
will make you to elicit in the your exam, somewhere they'll ask these signs, better know them properly. Fine. Now, let us discuss something about seizures. I told you the mechanism. In fact, already I told you, explain to you people the mechanism of what? Mechanism of what? Seizures in
Yes, sir.
meningitis. So, around 20 to 40% of the patients will develop what? Seizures. Only around 20 to 40%. This is higher in case of encephalitis. If the patient has got encephalitis, this incidence is more. So it could be focal or generalized seizures. As I told you, focal could be because of ischemia or infarction. Generalized could be hyponatremia, cerebral anoxia, toxic metabolites. Okay. Toxic metabolites, all these will cause seizures. So raise intracranial pressure. We'll discuss about raise intracranial pressure. What is the normal CSF pressure, students?
Up to 120.
Right, less than
Sir,
this.
110 to 130.
Yeah, it is less. Okay, it is should be mentioned in a water, not a mercury. You can express in mercury, but it is usually measured in millimeters of water. That is because you connect it to this one, LP needle. We don't put mercury to measure there. That's how you just like CVP. How you measure CVP? We measure here millimeters of water. You have to express it. Okay, more often because of that we express in terms of. And in the patients of meningitis, it is more than 180. 180 millimeters of water. You should remember. And in among the 20% who are very severe, it will be more than this much, more than 400 also it can go. In bacterial, it can go. And when the raised ICT will also cause reduced level of consciousness, And this is the one sign which is papilledema. You should you diagnose with help of what? What? Ophthalmoscope. Yeah. If with the help of ophthalmoscope, if you can pick up a papilledema, it is a very good sign of raised intracranial tension. So if you got a papilledema, then for doing LP, you should be very careful because there can be herniation of the brain. I'll come to that. I'll explain those things also. So papilledema can be one of the dangerous signs. So for doing LP, better avoid, or if you still have to do because you're not able to treat him properly, then do guarded LP. It is very, which will take a lot of risk can do that. Okay, papilledema can be picked up with ophthalmoscope. The pupillary reflexes will be damaged because of due to raised ICT. The third nerve compression can occur in the base of the brain because of third nerve transtentorial. What is a tentorium? This is a skull. This is a skull. Here there is a tentorium here. This is a pituitary fossa here. Posterior fossa, this is the posterior fossa. Here is the tentorial, transtentorial cerebrae. Tentorium cerebrae, it is there here. So the cerebrum here, transtentorial herniation will compress the third nerve here. Third nerve which comes here, which goes to the eye. So third nerve pressure on the third nerve, pressure on the third nerve can cause pupillary abnormalities. It will cause poor reactive pupil can occur, can dilated or constricted. And even sixth nerve palsy can also happen. Sixth nerve palsy will cause lateral rectus palsy of the optimal sign it is again. And if there is a still herniation, severe herniation, raised ICT, it can decerebrate posturing can happen. Now, even if there's furthermore, these things will start. Bradycardia, irregular respiration, all these things will start. Raised ICT can cause this. These are the very ominous signs. In fact, these two are very ominous signs. Even this is also there. They're all bad signs only when you start getting all the signs. These things means very bad. Patient is very bad. He may not do well. He may not recover. Okay. Diagnosis. How do you diagnose a patient of meningitis? Students, how do you diagnose a patient of meningitis? So,
By sir.
first thing is if you suspect, don't keep quiet. If you suspect the patient is having meningitis in the middle of the night, don't keep quiet. Treat him empirically. You may not be able to make a proper diagnosis with the, you may not be able to prove your diagnosis with the investigations. If you suspect, start treating. Before start treating, all the books do tell, take the blood culture. In periphery, these things are very difficult, but you should know at least from MCQ point of view. On suspicion, take the blood culture, try to get, and start empirical antibiotic therapy. LP may not be possible in the middle of the night for you people. So obtain antibiotic therapy, and if you're suspecting raised intracranial tension, you may not even, if you don't know, you are in the middle of the night, you're not, don't have ophthalmoscope, you're not able to really rule out the raised ICT, then start antibiotic therapy. Don't worry, empirically. I'll tell you the drugs which are to be given empirically in a patient who have suspected meningitis. You have to start the antibiotic therapy empirically. And of course, also give this dexamethasone. Why? Dexamethasone is because what is a major cause of damage? It is host
Inflammation.
defense. Yeah. And dexamethasone is definitely indicated in a patient's book. Do tell. Some of the books do keep on telling. Those are the books which are written long back, or the authors who have referred to long back books. They make this a controversial treatment. Dexamethasone as a controversial. Now, 20th edition of Harrison has definitely put this. In fact, this is what sentence I put it on. It is a copy paste. Blood culture immediately obtain the sentence. I just copied and put it the way. If you okay, so dexamethasone is definitely advised in a patients of pyogenic meningitis, even if it is empirical. That is to protect the brain and damage, because these exudates, when they increase, they can cause blindness, deafness, and all those things, because they can constrict the optic nerve. They can cause a lot of havoc there. Huh? Papilledema, and all these things will cause optic atrophy. So many things can happen. So by giving this dexamethasone, you may protect the patient from getting into this damage. Of course, anyway, you are giving a good antibiotic coverage. Let this be there, and the host let us protect ourselves from our own defenses, which is actually causing problem here. So dexamethasone is definitely indicated in a patient of pyogenic meningitis. Even Harrison has mentioned it. In fact, it is a sentence which are copied and pasted here. Okay, blood culture should be immediately obtained. Antibiotic therapy should be started immediately, and adjunctive and dexamethasone has to be given. Fine, that's what I returned. I'm just checking it because I kept your chart box above the slide here. You can see. Okay. Anyway, so these are the empirical treatment you start. Now, once you are comfortable, there is a no raised ICT, intracranial tension, then you can comfortably do CSF examination. Comfortably do CSF examination. So you have to tap the fluid from the lumbar puncture and send it for examination. So the antibiotic should be initiated few hours prior. Yeah, one more thing. Now you may really worry if you give antibiotic therapy, you may not be able to pick up the organism. Am I correct? That is quite natural. So if you give antibiotics few hours in the middle of the night at 12 o'clock or 2 o'clock, next day morning you send it for gram stain or LP and all that. That will not change the gram stain and PCR result. You can still do gram stain and get a PCR and try to pick up the etiology for meningitis. Antibiotic therapy initiated few hours before LP will not alter the gram stain and PCR. That you should know. Okay. Now, what are the CSF findings you get in a patient with the bacterial meningitis? As I told you already, the pressure will be high. Then pressure will be high. Okay, pressure will be high, and the white blood cells, the increase in white blood cells. I told you the CSF doesn't contain any cells, white blood cells. If there are more than 10, it can go up to 10,000 per microliter. Predominantly neutrophils here. In bacterial or pyogenic meningitis, the predominant cell type is neutrophil. You should remember this. This is important. And if you have done a traumatic tap, you may get some red blood cells. Okay. By doing LP, we cause some trauma, and that trauma will make the blood to seep into the CSF, whatever you're drawing, and that traumatic LP can make the red blood cells to appear there. And the glucose level is low in a patient with bacterial meningitis. Bacterial, fungal, and mycobacteria also it can decrease. Whereas in viral, the glucose level doesn't decrease much. These are the findings you should keep in mind to differentiate actually. That's why I told you this. This is not absolute finding actually. The way he has put it here, it depending on the blood sugar, the normally it is 2/3 normal CSR. Okay. So in a patient with pyogenic meningitis, it will come down even further. Further. Okay. So some patients of bacterial meningitis can have hypoglycemia. So if you are treating with a 25% dextrose, of course you can definitely start the 25% dextrose and do LP. It will not alter the CSF blood glucose that fast. It will take some time. 1 or 2 hours it will take to balance itself with the CSF. Okay. So you start if you want to give correct hypoglycemia, correct it with 25% dextrose and still do LP immediately there. Don't delay too much, but okay. And the ratio has given here. CSF serum glucose ratio here it will be less than 0.4. And the protein content in the normally protein content of CSF is less than this. Not the milligrams it is, sorry, you can put Yeah, milligrams. 45 milligrams. It will be. Now here it will be more. It can go in grams also. You can go into grams. From milligrams to grams it can go. 1 to milligrams can go up. It will be more than 45. Okay. Hmm? And gram stain you may get it. Hmm? Gram stain you will be able to do pick up the organisms which is cause for that. And culture definitely you can do. And PCR is a one really good technique. And latex agglutination test is a more sensitive and if it is available, you can get it done for these organisms. And still all these things you can do that. And latex agglutination test you can use to diagnose, pick up the organism, the cause etiology of the meningitis. Now, this table is to tell you the difference between uh, bacterial and bacterial and uh,
Viral and
tuberculosis,
microbe.
fungal, what? Viral, yeah. Basically, viral, tuberculosis, fungal, and bacterial. How they are there? You see, in viral, the count is not so high. Here, the bacterial can go like hell, but the count will be less than, although it is high, it will be less than 2000 viral. In tuberculosis, it doesn't go. Only here, in bacterial, it will go very high. It can go like, because pus, it can become, appear like pus only. In a very bad case, you may feel like as though it is so cloudy, then you may actually think of as though am I dealing with a pus? So bad it can be. Yeah. And predominant cell count is lymphocytes. In tuberculosis, it is a monocyte or lymphocytes. And here predominantly lymphocytes. And here it is neutrophils. So in bacterial meningitis, if you got predominant neutrophils, think of bacteria. Of course, even in these diseases, in initial stages, neutrophils can predominate. But they soon, within less than a week, they will get converted into this these cells. But initially it can be, but more often they are they jump to these cells. Glucose is normal in viral meningitis. Tuberculosis is less, it is decreased. The lowest, the fungi will eat lot of sugar. You should remember this. They'll eat away all the sugar and make it low. And see, the lowest is here, second lowest is here, is the third lowest. And this is normal. So the lowest sugar is this one. Next one is this. Next one is this. The last one is this. Okay, it is normal. So lowest sugar is it always the fungi. Next comes our bacterial. Next comes our tuberculosis. Or then the last one is viral, which is almost normal like. Almost normal like. Okay, almost normal like. Okay. Proteins. I'll discuss about protein now. Proteins are. Hold on. Yeah, you can see the highest level of protein increase is in a what? In bacteria only.
Bacteria.
Highest level of protein. Here also, there everywhere it is increased. But in fungi, it is not much increased. Remember, this protein increase is not there in fungi. They don't increase the protein. But here also there is an increase. Fungi, the protein are not much increased. Whereas all other places it is increased. Okay. Hold on, I'm just in the windows. Okay, next slide. Okay, latex agglutination test is used for this. Just I told you this. It is used for to diagnose this, and it has a very good sensitivity and specificity. Near 95 like that. A very good this one sensitivity. It can be used to diagnose these organisms. So differential diagnosis. When you see we get a patient of meningitis, you definitely have a lot of differential diagnosis. So the differential diagnosis, first one is viral. Always they would come into viral. And I told you how to differentiate viral meningitis. It was encephalitis, the signs of level of consciousness, all things will be there. If it is viral, the signs, those glucose level and protein level and type of the cells will give you the clue to diagnose. And if you don't know, in empirical treatment, you can definitely start as cyclovir. If you're just confused, you got a picture of the patient, you're not able to rule out the possibility of viral encephalitis or viral meningitis, start them on antiviral therapy also, or cyclovir. Along with the antibiotics. I'll come to the empirical treatment, I'll discuss this also. If you're not able to rule out this viral, within the clinical picture, you can empirically start antiviral drug or cyclovir in a patient with meningitis. Okay. And rickettsia. So this Nigeria meningitis can cause rash. Along with meningitis, it can cause meningococci, it can cause rash, adhesions and all that can cause. This is a rickettsia, rocky mounted spotted spear, can also present with the fever, headache, vomiting and all that. Level of consciousness can also be down there. And they will have what? Rash, purpuric rash, especially on the distal part of the body, on the palm, on the wrist, they can develop. And if left untreated, it can lead to gangrene. That can be the one thing. And what is the drug of choice for rickettsia? Doxa?
Cycling.
Yeah.
Doxycycline.
So empirically, you can add this also. If you're not able to prove the diagnosis, if you got patient has got a rash with the meningitis, better add this. You may be dealing with actually Nigeria only, you never know. If it is not an epidemic situation of epidemic of Nigeria, even rickettsia also can come in epidemics. Okay, if you then add up doxycycline. Doxycycline. Similarly, this is also one more tick bite issue. And I forgot to discuss about difference between cerebritis. Okay, difference between encephalitis, cerebritis, and cerebral abscess. So, what is encephalitis? Generalized inflammation of the brain. Cerebritis is a focal. But here, see, this is a brain. In encephalitis, everything is involved. Okay, cerebritis means only little part is inflamed, some focal areas, but it is not capsulated. It is still not capsulated. There is no capsule. When it forms a capsule, it becomes abscess. Okay, cerebritis means there is a inflammation of the focal areas of the brain without having the capsule or liquidification. They should be there. So in a capsule, if it forms a capsule, then it becomes abscess. Okay. Focal suppurative infections also mimic. In fact, it can be a complication. But even focal cerebral abscess can also mimic. You will really get confused because CSF findings will point towards a meningitis, but the patient has got predominant focal signs, focal seizures, and all that. If you got a focal seizures, better get CT scan. Try to rule out this focal suppurative and other possible causes of which are mimicking. Even some the craniopharyngioma tumor, if it breaks down, if it puts its cells into the ventricle system of the brain, can also mimic meningitis. You should know this. So that's the reason CT scan. Apart from raised ICT, we need to rule out these focal diseases. We need to rule out the focal disease. That's why CT scan is indicated apart from knowing the raised ICT. This is one more reason. This and subarachnoid hemorrhage, I think so I discussed, will also come with the headache, vomiting, loss of consciousness, and nuchal rigidity, meningeal signs. This also can come. Written here, rupture of tumor contents of the CSF. Written here. Okay, these are the differential diagnoses for meningitis. So, as I told you, the empirical treatment, which is one of the most important thing when you deal with the meningitis. Okay. Here, in an empirical treatment, on the first I written dexamethasone. Dexamethasone, you should give before. In fact, the books Harrison says started before giving antibiotics. That's the reason he is told. That's much he has told. Now, the drug of choice, and when you're dealing empirically, give third or fourth generation cephalosporin, ceftriaxone, cefotaxime, cefapime, especially if you're thinking of Pseudomonas here. Cefapime. Better give it. So ceftriaxone is the most commonly prescribed drug. Of course, if you're suspecting listeria or all this immunocompromised stuff and all that, better give this cefapime. And if you're thinking of the drugs, vancomycin can also be added for treating staph, and acyclovir for HSV encephalitis. Because if you are not able to rule out the viral possibility, because CSF is giving some neutrophils, some lymphocytes, and patient has received some treatment, and your CSF is really confusing you. You don't know what is the real picture. So patients before coming to you would have already taken antibiotics from a general practitioner. So much of issues can come up, and the clinical picture and the CSF findings is not very diagnostic. So in such a case, start as a clavier also, intravenous, especially to rule out HSV encephalitis, leading disease of one of them. And if the rash and all that, start this doxycycline. These are the empirical regimen in a case of meningitis. Of course, if you get a final diagnosis of the blood culture, you can definitely switch to the sensitivity pattern, going by the sensitivity pattern. But if you're doubtful, still you're not confirmed, better uh, uh, give a blanket treatment, because you may not get option data to treat the patient. Okay. Now I'll go to the next slide. Okay. Antibiotic therapy depending upon the organism. This is a table which I taken from the Harrison. So if there is a, see, when you're actually the Neisseria, the best drug that can be given is actually penicillin G only. So if you are giving penicillin G, you should be sure it is Neisseria, and you should also be sure that it is sensitive still. So if you are sure that, if you confirm the sensitivity, then you can start the patient on penicillin G or ampicillin. Okay, penicillin G or ampicillin. Otherwise, you straight away go with this drugs, which is broad spectrum, ceftriaxone. So even similarly for streptococcus pneumonia, penicillin sensitive to penicillin G. Intermediate, go with ceftriaxone. Penicillin resistant, start with the ceftriaxone or plus vancomycin. If the patient is having penicillin resistant, start them on vancomycin. That is along with ceftriaxone. That's why, apart from the staph, the vancomycin, the advice is because of this penicillin resistance. And if you're, this is the commonest organism which causes meningitis, and there's a possibility that it is a penicillin resistant. So add ceftriaxone and plus vancomycin. There's a combination they give. This is an empirical treatment. And gram negative bacilli, Pseudomonas of ceftriaxone, and Pseudomonas meropenem. Yeah, meropenem is better actually. Even ceftriaxone can also be given. Pseudomonas meropenem has to be given if you suspect Pseudomonas, and staph, vancomycin, and gram negative bacilli, Pseudomonas actually ceftriaxone will give again. Even cefapime, fourth generation can be added here. And methicillin sensitive staph, methicillin, neficillin resistant, vancomycin. Listeria, this is MCQ, ampicillin plus gentamicin. They asked some MCQs on the Listeria monocytogenesis. What you give is gram positive coverage. This is ampicillin plus gentamicin has to be given. Haemophilus influenza ceftriaxone. Streptococcus alligatae, where you get this? Newborn. Penicillin G or ampicillin. So in a newborn, ampicillin or penicillin G has to be given. Bacterial fragilis, metronidazole. Physiform bacteria, metronidazole. These are the drugs that have been advised depending upon the organisms. Yeah, depending upon age group now. Depend on the age group also, the way you can choose. Say this because again it derived from that. Less than 1 month, you are thinking of B group streptococcus. That's why you give them ampicillin and cefotaxime. And infants 1 to 3 months, Haemophilus influenza is there here. Ampicillin and cefotaxime or ceftriaxone. And immunocompetent, yeah, the more than 3 months to 55 years is ceftriaxone plus vancomycin. Then more than 55 years, you are thinking of listeria again, ampicillin, cefotaxime, cefapime, and vancomycin. So for listeria, what is the drug has been advised here? Ampicillin. Ampicillin. That's why in old age, you should always add up ampicillin. So ampicillin here and here. That's why. In less than 1 month and more than 55 years, you are supposed to add ampicillin. Okay, that is to cover listeria. Otherwise, vancomycin and ceftriaxone is to cover streptococcus pneumoniae actually, or Neisseria, whatever. Hospital acquired, you may be dealing with staff, so that's the reason. So Pseudomonas, meropenem is added here, apart from ampicillin, ceftazidime, or meropenem or vancomycin. Now, till now, any doubts, students?
No, sir.
No doubts.
sir.
You're bored or what? Now we'll discuss about MCQs now. Okay.
Yes, sir.
Tell me, a patient presented with patient has presented to you with headache. Patient presented with the headache and fever for 7 days. While doing the lumbar puncture, it was noticed that the opening pressure of the CSF was increased on jugular vein compression and became normal on relieving it on jugular venous pressure on jugular vein. What is the interpretation? Now, patient is, you are suspecting a meningitis. Now you are doing CSF, a lumbar puncture. So you compress the jugular vein. You are actually measuring the CSF pressure. Sorry. Now you are measuring the CSF pressure while doing the lumbar puncture, and you press the jugular vein. The CSF pressure in the measurement get increased. On relieving, it get decreased. What does it suggest? Does it suggest subdural blockage, subarachnoid blockage, or subarachnoid villi blockage, patent subarachnoid space?
Sir, you told no, there is sagittal sinus block maybe there.
Yeah.
Sagittal block.
Subarachnoid blockage.
Now, if there is a sagittal venous block, so while pressing the jugular vein, so how does jugular vein, how they enter the brain to sagittal vein again?
Those
So if
sinuses
there is a
will
block,
form.
so what do you think? Subdural blockage or subarachnoid blockage?
Subarachnoid, sir.
Confused between those two, sir.
Okay, we'll give both of them. Others?
Subarachnoid, sir.
Okay. Subarachnoid. Anybody want to type? You type the answer. Now, this is a jugular vein. This is the brain. Fine. Jugular vein, it will drain through the what?
Jugular foramen.
Sagittal veins. So the sagittal sinus, the blood in the sagittal sinus to the stanza cerebrae, it will enter into the come down. Fine. To the heart. It goes down to the heart. Am I correct?
Yes, sir.
It will form confluence sinuses.
What?
It will form on confluence sinuses. That means
ultimately it will drain into the your internal jugular vein.
Yes.
Am I correct? There are
Yes,
no
sir.
lymphatics in the brain. Always know
Yes,
that.
sir.
There are no lymphatics in the brain. It can be an MCQ. So it will drain into the jugular vein ultimately. That's how it can reach the heart. There is no other way. Now you press the jugular vein here. So what happens here? The pressure here increases or decreases inside? Above. It should increase if it is draining down. If it is draining down, or it should increase. whatever blood is coming as you know, it's increase. Okay, it should increase. Now, if it is increased, it should reach the subarachnoid space. It should increase the subarachnoid space. Thus, only your lumbar puncture pressure will go up.
Yes, sir.
If that is blocked, they're disconnected, na?
Yes, sir.
Yes, sir. Fourth option, I think. So, no.
Yeah. The fourth option. This is called as, I don't know how to pronounce it. You want to pronounce this? How you pronounce it? Somebody pronounce it for me.
Cook and state maneuver.
Whatever. Some cook and studs maneuver. I don't know how to pronounce it. You people remember somehow. I don't know how to tell you this. Quick and studs. Maybe. Yeah, am I correct now? Quick and studs maneuver. It is called that actually. Pressure and ICV, increase venous congestion. Same thing I have told you. Okay, it will take some seconds to manifest. Fine. Now, which are the patient with the undulating fever? Now you got a patient with the undulating fever. Presents with the undulating fever. Features of encephalitis. He is treated successfully with doxycycline and rifampicin. What is the diagnosis?
Option 3.
Brucellosis, Bordetella pertussis, Franconia tularensis, Mycoplasma.
Tularensis.
Brucellosis, sir.
Yeah. See, the doxycycline rifampicin, that is the one patient. Now you give this drug for brucella. Madam has finished brucella, communicable diseases. She has covered. I
Yes,
don't know.
sir. Yes, sir.
Brucella, I don't know. I don't remember. I have to ask her. Brucellosis, the treatment is these two drugs. Now, brucellosis definitely can involve encephalitis, can cause. Spinal cord involvement is there. It's not. So this is a treatment. This is a question. Fine. A patient presented with a history of fever for 3 days with headache and photophobia. Now 3 days headache, photophobia is there. Raised ICT is there. On examination, Kernig's increased Kerning signs. Sorry, somehow I don't know why I put it this way. Kerning signs is positive. CSF increased pressure is there. Report mentions lymphocytic count. There is a Kerning sign and CSF pressure is high. With the what is there here? Lymphocytic count is this much 36 per ml with a normal glucose with increased protein level, increased opening pressure, identify the etiological agent. Now what you have got is lymphocyte, increased pressure, and glucose is normal. Where you got normal glucose? Increased
Virus.
Coxsackie virus, sir.
Yeah. If it has proteins are normal in fungal. Fine, it is increased here. Glucoses are very much down in fungal. Yes, I'm trying to memorize all those things. So you have got an increased protein here. So it is Coxsackie virus. Now, patient present with headache and fever. You suspected meningococcal sepsis. You have suspected it already. Which of the following antibiotic is recommended as the first line for empirical therapy?
Penicillin G.
Empirical therapy, no. You're not confirmed it.
Ceftriaxone.
Better go with ceftriaxone.
Ceftriaxone.
Yeah, because it is empirical. If it is suspicion, still suspicion. Penicillin G is the best drug, but the sentence contains empirical therapy. Focus on this. Because of that, it goes here. Fine. And if it was specific therapy, probably this would have been given. But you should always remember when you're dealing with meningococcal, you're giving penicillin G, confirm that you are having a penicillin sensitivity. In fact, if you after culture report culture sensitivity, you can migrate from ceftriaxone to penicillin G. Fine. What is the correct sequence? What is the correct sequence to be followed in a suspected bacterial meningitis? Now, how do you approach a patient? Like that, they're asking you. How do you approach a patient? What is the correct approach? Draw blood culture sample. The first, how do you draw a blood culture sample? Empirical antibiotics, neuroimaging, followed by LP. This is the first approach. Second, start straightaway antibiotics, neuroimaging, blood culture sample, followed by LP. Second thing, LP, empirical antibiotics, and CSF culture. Empirical antibiotics, mannitol, LP, followed by neuroimaging. Which of them is correct?
First ones.
So four.
First one, sir. First one, sir.
First one.
Why you think fourth one? Huh? See, we cannot say that. Actually, at least from the textbook point of view, we cannot say that I can't draw blood culture. Huh? Even if you are dealing in PHC, you are supposed to have blood culture bottles there. I don't know whether they're available. Maybe in a periphery, you may end up doing this. This one. But when it comes as a question, this is the correct answer. So draw blood culture. Start
Sir, one second, sir. This fourth option, sir, empirical antibiotics, mannitol, LP followed by neuroimaging, sir. Mannitol reduces intracranial tension, sir. Then we can do LP.
Yeah, that can be done, but drawing blood culture is not there.
Sir, before blood
See,
culture,
you
if we
see, LP
give
followed by
empirical-
neuroimaging as given. Say, why should you
Yes,
know?
sir.
LP followed by okay, that is correct. There's patches and active sentence. Reverse it. So of course you give mannitol. Mannitol, why you want to give mannitol when there is no raised ICT? Confirm neuroimaging, then give mannitol. Or if you are neuroimaging, is see the clinical setting where you are practicing, so many questions do come. As far as textbook is concerned, this is the correct answer.
Yes, sir.
So whenever these books are and the questions are asked, they expect that some clinical setting where some facilities are available. Like that, they imagine and put it in a put a question to you. So you should try to pick up with at least on PHC like picture and try to make a meaningful diagnosis out of it. Okay, I know when you're practicing somewhere, things will differ. That do happen. You will end up giving antibiotics and send for CT scan and LP. That's what is going to happen. Drawing blood culture in a peripheral set, otherwise setup is very difficult. Blood culture and all that. But if you actually, the books do say draw blood culture, then antibiotic, neuroimaging followed by LP. That is the correct answer. Okay. Now, can you see the diagram here? Huh?
Yes,
Huh?
sir. Capsulated.
I kept your chat box along up above that. That's why I'm asking.
Pneumococcal, sir.
Meningococcal. First option.
Where is meningococcal?
Pneumococcal, sir.
Meningococcal meningitis.
Yes,
That
sir.
is
Manju, where did you find meningococcal choice here?
no, sir. That first option, sir.
That is
Pneumococcal, sir.
pneumococcus.
Sir,
Diphtheria
diplococci.
meningococcal. That is different. Okay.
Sir,
Huh?
diplococci, sir.
Okay, good. But this Indian ink preparation, you did not check this. Focus this. Where classically you now you see now, yeah, so many things are there here. You got to really worry about when you deal like this. 50-year-old woman with immunosuppressive therapy with steroids, with post kidney transplantation. She presents with a 3 days history of fever, headache, and confusion. LP shows 200 pm.
Neutrophils.
200 pmn. What does that suggest? Bacterial, fungal, polymerponucleosides, bacterial.
Bacterial.
Okay. With the
Bacterial.
elevated CSF protein, what happens in fungal? Normal. Protein is normal.
Normal, sir.
Elevated there. Yeah. Kidney. And with the an ink for Indian ink, I don't know why I don't have kidney here. Indian ink.
ink.
I don't know why it is Indian ink preparation. Slide is shown in down here. What is diagnosis? Now increased protein is there, PML is there, that also has bacterial only. Okay, CSF protein is normal in fungal. So a polymorph is bacterial. Now Indian ink preparation means what do you think? You think of Cryptococcus actually.
Yes, sir.
Always. That is a one thing. HIV, Cryptococcus, Indian ink preparation, classic mug-up. That's why they give this question. But even if you don't know how to read this, still you can pick up from a real 200 malfluorescence, proteins, Indian ink preparation. But this is diplococci. You can see this is diplococci. So it is the answer. Pneumococcal meningitis.
Sir, why he has given immunosuppression, steroids, kidney transplant and all?
To confuse you?
Is it to think fungal like?
Yeah, to confuse you only has given it.
Okay.
To confuse you, he wants you to go for cryptococcal and mess up. But these findings which are there, and this slide, so many findings are there. You have to, if you know the theory and diplococci and all that, then you'll pick up. It is question twisted to confuse students. That's all. There is no special purpose here. And this is the one you can see. In cryptococcus, you can see this budding. Indian preparation of cryptococcus meningitis. Okay, it becomes budding here. Okay.
Yes, sir.
All are true about lumbar puncture except needle should be inserted in cephalid correction toward the head. Lateral recommended position with the bevel of the needle should be up. Leg should be straightened during the measurement of opening pressure. Needle inserted at the L1, L2 space.
Option
Fourth
4.
option, sir.
Yeah, where you want to put the needle?
L3, L4, sir.
L.
Very good. L4. Now let us go in more detail into lumbar puncture. How many of you have done a lumbar puncture? Students, how many of you have done lumbar puncture?
Sir, I have done.
Manju, you have done. Then who else? Roshan, have done. Vandana.
Sir, no, sir. I
Who
just
is
watched. Sir.
Arva? Who is Arva? ARWA Arva. Somebody. I'm not about. I don't know.
Sir, she is my friend, sir.
Okay. So she has. So Arva, how have you done
She
lumbar
also clear, sir.
puncture?
So no.
No. Okay. Okay. Anyway. Now lumbar puncture. Okay, we'll discuss more about this. Lumbar puncture. Right? Lumbar puncture. While doing lumbar puncture, patient should be brought to the edge of the bed. That means if this is a bed, this is a bed. The patient should be brought to the edge of the bed. So he'll be sitting here, doctor will be sitting here. So patient should be brought to the edge of the bed, so that you don't get backache. If the patient goes deep into the middle of the bed, you will get backache. That's how the patient should come to the edge of the bed. Neck should be little bit anti-flux. It is anti-flux, and thigh should be pulled up from the abdomen. Anti-flux pulled up from the abdomen. Okay. Shoulder and pelvis should be at the same vertical level. Patient is in lateral recumbent position. Same vertical level. And L3, L4 is a puncture site. Needle is directed 10 degrees cephalid. That is how we used to do it is towards the umbilicus. Check for the umbilicus, site directed towards the umbilicus of the patient. That will come to this much. 10 degrees. And the needle size, this is the gauge. And pressure recording, 3-way stop. This yes is wrong. Extend the lengths and bring back the neck to the natural position and check the pressure. And it varies with the respiration actually. It varies with the respiration. This is how we measure the pressure. Less is CSF when compared to all except. What is less in CSF when compared to all? Plasma, when compared to plasma. Sorry. This is plasma. So, what is less in CSF compared to plasma? Except. And what is more in CSF compared to plasma? The question could be very simple. They try to put you into trouble. What is more in CSF compared to plasma will be straightforward question. What is
Fluoride.
huh?
Fluoride.
Fluoride.
Glucose is 2/3 of it.
Yes.
Protein is in milligrams, whereas in the blood it is in grams. Am I correct? Calcium and chloride. You have to tell me. Which is the answer?
Fluorides.
Fluoride, sir.
Very good, very good. So these are the levels. Glucose, plasma, it is less than like fasting and is 2/3 of it. CSF. Protein is in grams here, it is in milligrams here. Calcium is 9 to 11 milligrams, whereas this 2 to 3.2. Whereas chloride is 120 compared, whereas this is 106. 32-year-old female presented with headache and nuchal rigidity. Presented with headache and nuchal rigidity. What do you think? 32-year-old AIDS positive female presented with headache and nuchal rigidity. On lumbar puncture examination, it was clear CSF. CSF is clear. That means probably not much of protein, leukocytes and all that. Maybe less if not. So clear CSF was obtained with leukocyte count of so much, just 100. Indian ink preparation was positive. The probable diagnosis.
Cryptococcal, sir.
Meningitis. It is not. Sometimes they can harbor in HIV patient without causing, without. Did I stop sharing?
Yes, sir.
Hold on. I don't know what it's on the first one. You're seeing full screen?
Yes, sir.
I am not seeing it. Okay, you are seeing now. Screen sharing is paused. Can you see screen? Students?
Yes, sir.
CNS part 2.
Sir,
You
it
are
is
able to see the
CNS
screen?
part 2 epilepsy.
Are you able to see the screen?
Yes, sir.
Yes,
Oh.
sir. But it's the slides, sir. These are the slides given.
Different topic.
Okay, then I'll stop share. And again comes on more. Fine. Yeah, this one. Okay, now?
Yes, sir.
Okay. So it is a meningitis, It is meningitis. Sometimes in HIV patient they may just be there without causing meningitis. So when there is all the signs of fever and all that, you pick up this. It is meningitis. Drug of choice for Listeria monocytogenes. You want me to answer this?
Ampicillin.
Yeah.
Ampicillin, sir.
A patient presented with headache. Patient presented with headache and nuchal rigidity, lumbar puncture was performed, and CSF had normal protein and normal glucose. CSF had a normal protein and normal glucose with a clear CSF. Microscope examination showed 50 lymphocytes and lymphocytic pleocytosis. What is the diagnosis?
Viral.
Fungal.
Neoplastics.
Neoplastic meningitis. Why you expect lymphocytosis there? Neoplastic.
Sir, I am thinking of pleocytosis.
What do you mean of pleocytosis? What is the meaning of pleocytosis? Any cell who has got a nucleus, if they are presented in the CSF, it is called pleocytosis. More often they are PMN, polymorphonuclear, or even lymphocytes also can be included. But actually when you talk of pleocytosis, you are actually telling about polymorphonuclear cells, that is neutrophils only. But lymphocytic pleocytosis and inflammation, they are all signs of inflammation. Neoplastic meningitis, nuchal lumbar puncture CSF, normal protein and normal glucose. With the CSF microscopic examination, And lymphocytic pleocytosis is there, na? That's why I want to go for
Viral.
viral. Huh?
Yes, sir.
I will go for viral. And this can be a good differential diagnosis. Huh? Which of the following is not seen in tubercular meningitis?
Sir, previous question, sir, please.
Yes, go ahead.
Sir, here it is CSF showed 50 lymphos.
Less than 500 viral.
Tell me
And
what.
again he is saying lymphocytic pleocytosis, sir. What is the meaning of those two?
They is telling there is some amount of neutrophils also. Probably. This word is given in Harrison. Pleocytosis means like lymphocytic pleocytosis is seen in the viral. That sentence is there. That's why they put it. There will be some amount of neutrophils. There are cells in there. See, all of them will not be lymphocytosis. Predominantly it is lymphocytosis. So he wants to tell you that apart from lymphocyte, there are other cells also. That's what he wants you to think here. Even PMN also is there, but they are less in number compared to lymphocytes. Pleocytosis, as far as definition is concerned, it suggests only nucleated cells. Okay, that's the reason. We'll go for that. What is not seen in tubercular meningitis? Students, what is not seen in tubercular meningitis? Evidence of old pulmonary lesions or miliary pattern is found in chest X-ray. Can you get this in a patient with tubercular meningitis?
Yes, sir.
It can be there. It's not that it can't be there. Culture of CSF is diagnostic in majority of the cases and remains a gold standard.
Yes, sir.
If you can prove it by culture, it still becomes a gold standard, but it is very difficult to do. That is a different question. It is seen in most often in young children, but also develops in adult. Young
Yes,
children
sir.
are more prone to develop tuberculosis meningitis compared to
Microbial.
adults. Cerebrospinal fluid reveals low leukocyte count. That is wrong. It will be more only. Okay. That is
Yes,
the
sir.
answer. Aseptic meningitis is caused by
Ibuprofen.
Option 2.
ibuprofen. I told you that just now. While taking chemical induced meningitis, I told you that. Fine. It is ibuprofen. So these are the causes of aseptic meningitis. So aseptic meningitis, because you're not able to demonstrate the organisms, that is what it means actually. Okay. What aseptic meningitis? Aseptic means you are not able to prove the diagnosis there properly. It's your problem actually. But that can be really aseptic like this, no organisms like this. These drugs, ibuprofen, cotrimoxazole, IVIG, Guillain-Barré, all that we give this now, and monoclonal antibodies. These things, or Lyme disease, leptospira, Mycobacterium tuberculosis. Although I said gold standard, it may not be able to prove also. Subbacterial bacterial carditis, parameningal infections. Parameningal, they'll cause signs of meningism. They also cause aseptic meningitis. Partially treated bacterial meningitis. Some people give antibiotic and send you. You are because of after 2-3 days, if the patient reaches you, you may not be able to prove the diagnosis properly. Is viral, you may not be able to diagnose them, and they will call them as aseptic meningitis. So that's all for today. And if you got any doubt, I am happy to answer. Students, anything?
No, sir.
No, sir.
Okay then. That's we'll call for the day. Fine.
Yes, sir.
Good night.
Good night, sir. Thank you, sir.
Anything? Who is asking? Okay, good night then.
Thank you, sir. Thank you all.
Sir? Sir, are you there?
No, sir is left already.
Okay.